Good morning, everyone, to the 16th annual Mario Varani Lectureship. As you know, Mario Varani was a professor of medicine here at Methodist and at Baylor when we were with that institution. He was director of nuclear cardiology from 1984 up until 2001 when he had an untimely death due to pancreatic cancer. Mario was a prolific investigator. He published over 200 manuscripts over the years. He was an excellent teacher and loved teaching and had such great enthusiasm for the field of cardiology and for nuclear cardiology and made so many contributions to the field. He was one of the first presidents of the American Society of Nuclear Cardiology and spearheaded actually the development of that society. And in terms of his scientific accomplishments, he actually was one of the founders of pharmacologic stress testing in terms of what we use every day of the week now in nuclear cardiology, starting with adenosine and now with regadenosine as a pharmacologic stressor. He was also my mentor, and from a personal note, you could not find a more humble and yet so sophisticated and well-versed individual in all aspects of life. And so every year, because of Mario and his contributions, we honor him with this particular lectureship. This year, we're extremely happy to have Dr. PREM SOMAN, who will be giving the lecture this year. Dr. SOMAN is Associate Professor of Medicine and Cardiology and Clinical and Translational Science at the University of Pittsburgh. He's Director of Nuclear Cardiology and Director of the Advanced Cardiac Imaging Fellowship at the University of Pittsburgh. And he has done extensive research in areas of heart failure, and particularly in dyssynergy and imaging of heart failure. And on a personal note, I can tell you that I have known PREM for many, many years, and I've seen him come up through the ranks in the different societies. And he's a personable, he's a good friend, and someone who I've really seen grow over the years in many, many ways. And he is going to be the next president of the American Society of Nuclear Cardiology, an honor which he truly deserves. And with that, I'd like to introduce him to give our lecture today in terms of advances of radionuclide imaging in heart failure. Dr. Soman.
Good morning. Thank you, John, for that very kind introduction. I feel very honored to be here today. I did not have the privilege or the good fortune of actually meeting Dr. Varani, but his influence on nuclear cardiology and cardiology itself was so profound that it's a great honor for me to give this lecture in his name today. Now, this slide shows one potential scheme for evaluating patients with new onset heart failure. And in that circumstance, one of the first bits of information we often seek is whether LV systolic dysfunction is present. And in patients with LV systolic dysfunction, a critical step is to determine if extensive coronary artery disease, that is etiologically linked to coronary artery disease, exists. And in patients with coronary artery disease, I think today it's still relevant in selected patients to test for ischemia and viability. This despite the questions raised by the recent viability studies. And in patients who have ischemia and viability, I think it's an optimal method of selecting patients for revascularization. In selected patients with non-ischemic cardiomyopathy, we might want to test for specific etiologies such as sarcoidosis and amyloidosis. But in most of these patients, we are left with medical therapy, both for patients with non-ischemic cardiomyopathy and patients who have persistent LV dysfunction after coronary revascularization, ICD and CRT in most of these patients who fit the criteria, and of course advanced therapies such as LVAD, mechanical support and transplantation, in a select minority. Now, the arrows here show the steps along the way that nuclear cardiology and indeed all imaging modalities might help. Some of these applications, such as ischemia and viability testing, are traditional bailiwicks of nuclear cardiology, and others are emerging new applications. And what I'd like to do in the next 40 minutes or so is to use case examples to illustrate some of these applications. And I will start with sharing some thoughts about some nuances in a very traditional application, which is the diagnosis of ischemic cardiomyopathy. So this gentleman, an octogenarian, was one of the most healthy octogenarians I had ever encountered. Had excellent functional capacity, played 18 holes of golf every year, went hiking, but one morning was admitted with acute onset heart failure and acute pulmonary edema. No angina, with very good functional capacity. The echo showed diffuse LV dysfunction. EF was 25 to 30%. There was mild elevation in his troponin. And I think so many people asked him about chest pain that he eventually said, okay, maybe I do have some chest pain. Now, of course, we went down the traditional route. He went to the cath lab, and I realized this morning that these images don't play, so you'll have to take my word for it. He had modest triple vessel disease, an 80% stenosis, a very large, and the stenosis was very proximal in a circumflex coronary artery before the origin of a large obtuse marginal, so it did supply a large amount of myocardium, a long 80% modest stenosis in the mid-LAD, and a 70 to 80% stenosis in the proximal RCA. Now, our cath lab is very good with doing functional testing with FFR, but given the circumstances, the operator thought this is surgical disease, and so took him off the table, and we went down the traditional route of testing for viability. And this is our preferred protocol, nitrate-enhanced rest as technetium system imaging, and you can see that the entire myocardium lights up, and all of you know that this is good myocardial viability. He got referred for surgery, and as expected, I got a frantic call from Larry Way, my colleague, the surgeon, in the evening, because his chest x-ray looked like this. And he had had radiation therapy for lymphoma many years ago, and his chest x-ray had looked like this for the past 20 years. And he could hike, he could play golf. I was not worried about this, but the anesthesiologist was, understandably. And so the risk-benefit ratio for revascularization now had changed a little bit. And so we needed a little more information, and so I did a stress test. And I must say I was a little surprised, because as you can see here, there's no ischemia. There's no ischemia at all with a Regeneron stress test. And I wanted a second opinion, so I sent him for an MR stress. And here again, you can see with the first pass gadolinium perfusion, maybe a little bit of subendocardial ischemia here on the stress studies, but certainly nothing to explain the diffuse LV dysfunction. And it turned out that this is an example of a patient with coronary artery disease and coexisting non-ischemic cardiomyopathy. So I sent him home on optimal medical therapy, saw him 8 weeks later. His LV function had completely improved. You can see that he needed a pacemaker because I pushed the carvedilol to the maximum extent. He needed a pacemaker. And he lived without any adverse effects for, I think, about 5 or 6 years, and then died from complications of acute appendicitis, right? So what I'm trying to say here is, so if this guy had undergone bypass surgery, a few things would have happened, right? We would have said the recovery of LV function was due to successful revascularization of ischemic cardiomyopathy. That's how we would have interpreted it. So LV function would have recovered anyways. We would have said that viability testing accurately predicted recovery of LV function. This is what would have happened had I sent him for bypass surgery, only that he did not have ischemic cardiomyopathy. And this nuance, I think, complicates our interpretation of the viability literature in a very important way. And the point I want to make here is establishing the diagnosis of ischemic cardiomyopathy is just not the coexistence of LV systolic dysfunction and coronary artery disease, but in addition, we have to demonstrate one of the pathophysiological mechanisms by which coronary artery disease produces LV dysfunction. And they are finite. There are only a few mechanisms by which coronary artery disease produces LV systolic dysfunction, and that is either infarction with or without remodeling, or stunning or hibernation in the presence of significant underlying coronary artery disease. So this is the important point I want to make. This has got very important prognostic ramifications. Years ago, Michael Felker from Duke looked at their database of patients with known cardiomyopathy. And the practice in the literature is to call anybody with coronary artery disease and LV systolic dysfunction ischemic cardiomyopathy. That's how we've done it in the past. And you can see here that when these patients were followed up, patients with one vessel disease or limited coronary artery disease had the same prognosis as patients who had no coronary artery disease, and raises the question of the prognostic benefit of revascularization in these patients. And so they proposed a modified definition for ischemic cardiomyopathy, which emphasizes the presence of extensive coronary artery disease that is etiologically related to the LV systolic dysfunction. And indeed, when we looked at this many years ago, Jim Udelson, when I was working with him, looked at this in 200 patients with new onset heart failure using SPECT as the first test. You can see that it has a very good negative predictive value. A normal stress rest myocardial perfusion scan is a very good negative predictive value for ischemic cardiomyopathy, i.e. extensive coronary artery disease that is etiologically related to the LV systolic dysfunction. And so patients, heart failure patients who have a normal stress rest perfusion scan are very unlikely to have LV dysfunction that is due to coronary artery disease. Now, I use nuclear cardiology to illustrate this principle, but this is true if you use echocardiography, MR stress, and so on and so forth. So if you do perfusion imaging in a patient with heart failure, you can see three distinct patterns. The first is a classical dilated cardiomyopathy where the ejection fraction is low, the ventricles dilated, but the perfusion is completely normal. The second example here is the patient with a small cavity, thick ventricles, presents with recurrent heart failure. Perfusion is normal, and this is the classical heart failure with preserved ejection fraction. And then you have the ischemic cardiomyopathy, the dilated ventricle with multiple perfusion abnormalities, infarction or inducible ischemia, which is the traditional ischemic cardiomyopathy. So, to recapitulate, it's really important that when you're looking just at a resting study, it's important to remember that myopathy can confound viability interpretation. And it's my belief that the literature on viability is significantly confounded because we have not paid attention to this. So if you have a scan like this, it could be LV dysfunction due to CAD and viable myocardium, but it could also be myopathy. It could be a simple dilated cardiomyopathy, and you do need to do some sort of functional testing to make sure that these three pathophysiological states do not exist, and this is truly not ischemic cardiomyopathy. PET may have a particular role here, because as you know, in PET we do both flow and glucose metabolism, and this combination of reduced flow with preserved or increased glucose metabolism in that territory absolutely establishes the diagnosis of myocardial hibernation and predicts a very high probability of recovery of function after revascularization. And that is a unique and very important applicability of PET in this circumstance. Now, if you look at MR, the same principles apply. Here's a patient with LV systolic dysfunction and no gadolinium enhancement, no scar. What could this be? It could be CAD-related LV dysfunction and viability, but it could also be cardiomyopathy, right? And this distinction is very difficult to make just from the absence of scar. Now, MR has given us some very, very important insights. There are very characteristic macroscopic fibrosis patterns with different types of cardiomyopathy. Here is a patient with ischemic cardiomyopathy where you have the typical subendocardial enhancement that expands to become transmural. That's very typical of ischemic cardiomyopathy. With a non-ischemic cardiomyopathy, you either might not have any scar or you might have patchy mid-wall striae that are more characteristic of non-ischemic cardiomyopathy. In fact, in this study from Dudley Pennell, it was shown that even in patients without epicardial coronary obstruction, a small proportion of these patients have fibrosis that's very typical of ischemic cardiomyopathy. So that is ischemia due to microvascular disease. And again, a good illustration of the fact that what happens in the epicardial coronary arteries may not always reflect what's happening at the microvascular level. So the point I wanted to make is we are used to thinking about heart failure etiology in distinct terms, ischemic cardiomyopathy and non-ischemic cardiomyopathy. But it's important to remember that coronary artery disease can coexist with non-ischemic cardiomyopathy. Patients with hypertension, patients with diabetes, these are patients who also have hypertensive heart disease and diabetic cardiomyopathy, and these conditions can coexist, and then your expectation of improvement with revascularization has to be modified. So it is a clinically relevant concept. Now, in ischemic cardiomyopathy, there have been a few developments in nuclear cardiology that are clinically very relevant. One of the most challenging clinical diagnoses to make is sarcoid cardiomyopathy. And you know, the implications of making this diagnosis are profound because the dose of steroids that are used are almost invariably associated with side effects, long-term high-dose steroid therapy. And PET has a unique application here because FDG PET actually detects areas of active inflammation. So in addition to just showing anatomical evidence of infiltration, the presence of active FDG uptake tells you that this is not quiescent sarcoidosis, this is active sarcoidosis. In fact, Marcelo De Colli's team from the Brigham, led by Ron Blankstein, have shown very elegantly that if you do serial FDG studies and you can show that the FDG uptake is suppressed with high-dose steroids, then this is associated with an improvement in LV systolic function over a period of time. Again, clinically very, very relevant data. But the highlight of advances in specific cardiomyopathies has been the introduction of technetium pyrophosphate imaging for cardiac amyloidosis. And this is, at least I find this to be one of the most exciting developments in nuclear cardiology. As some of you might know, last year, a multinational study of 1,200 amyloidosis patients, which is a large cohort for cardiac amyloidosis, presented this data of unheard of diagnostic accuracies with technetium pyrophosphate. We rarely see numbers like this, 99% sensitivity and a positive predictive value of 100% for cardiac TTR amyloidosis. Now, here is an example of PYP scanning. It is a bone tracer, so you can see the bony structure silhouetted very nicely. And it's an example of a patient who clearly you can't see the heart, and so there is no uptake of pyrophosphate in the heart at all, in contrast to this other patient who has very avid pyrophosphate uptake. And most of the studies, the results are like this. They're black and white. And this is virtually diagnostic of ATTR cardiac amyloidosis. We almost always also perform SPECT imaging, and this is really important to confirm that the tracer is in the myocardium and not in the cavity. For example, in this patient, there is sort of mild uptake of pyrophosphate, and the SPECT shows this looks like a radionuclide ventriculogram. It tells you that the tracer is not in the cavity, not in the myocardium, it's in the cavity, and indeed, when we repeated imaging in a couple of hours, you can see that you don't see anything in the heart at all. So it's important to do SPECT imaging. The advantage of PYP scanning is that it's really simple to perform. It's a rest-only study, so you don't have to send patients home just because they've had a sip of coffee in the morning. It can be done in anybody, patients with atrial fibrillation, renal failure, large patients, ICD, CRT devices, contrast allergies. You send a patient for a PYP scan and they will get it. In my lab, this is a same-day test now. If you're in the clinic and you want PYP scanning, you call us and we do it. And it's a small radiation dose from standard therapy. Now, we were so surprised at how subscribed this test has become. In the last year, we performed about 150 PYP scans, and 36% of these scans were positive. And just from this arose the concept of a multidisciplinary cardiac amyloidosis center that we have now established. And I was telling John that we're in the process of recruiting for a basic scientist who will work with our protein conformational diseases center to just work on amyloidosis. So this is how the test has influenced how we see amyloidosis. It's interesting to recall that this is not a new agent. John and I were talking about other applications. It was used for infarct imaging, but it was tried in 1987 for cardiac amyloidosis, and it was thought not to have a good enough sensitivity for clinical use. And this is because at that time, we did not understand its tropism for ATTR amyloidosis. Now, if you recall, cardiac amyloidosis is of two primary types. You have primary AL amyloidosis, which is a plasma cell malignancy, and is formed from light chains that are secreted by plasma cells. It's a terrible disorder, and in lacking advanced chemotherapy and or bone marrow transplantation, prognosis is very limited in patients, particularly after cardiac involvement. The other type of amyloidosis is transthyretin, carrier of thyroxine and vitamin A completely normal protein that for some inexplicable reason starts to deposit in the myocardium as people age, and that is the wild type, and can also present as a hereditary disease, either as a cardiomyopathy or neuropathy. It is really important to remember that in this group, where they showed a sensitivity of greater than 99% and a specificity of 100% when performed in combination with serum studies. And it's really important to remember that this does not pick up AL amyloidosis. So if the clinical diagnosis or suspicion of amyloid is high, you have to do something else to exclude AL amyloidosis. It always should be interpreted in the context of serum studies. And the serum studies to be performed are free light chains and serum immunofixation electrophoresis. All labs do this. It's not the standard UPEP and SPEP that we've grown up with. They're not sensitive enough. And in my lab, to order a PYP scan, you have to order the serum study, so that we're always reading it in conjunction. There are other imaging approaches to amyloidosis. We've all grown up memorizing the ECG findings. It haunts everybody who's taken MCQ tests. This is a topic that haunts you. But I want to point out to the fact that low voltage ECGs are relatively rare in amyloidosis. And focusing on the low voltage ECG is one of the reasons that we miss a diagnosis of amyloidosis. You see it in about 50% of patients with AL, and that is thought to be due to the rapidity with which the AL light chains are deposited in the myocardium. The AL light chains, unlike ATTR fibers, are inherently myotoxic and contribute not just by mechanical myocardial dysfunction, but direct toxicity of the myocytes. And in ATTR amyloidosis, only 25% of these patients have a low voltage ECG. But if you have a thick ventricle on the echo and a low voltage ECG, that's almost pathognomonic of amyloidosis. But it is a rare finding. The commonest ECG pattern is a pseudo-infarct pattern or AV block. It's interesting, this is our own experience as well, that up to 20% of patients can have overt LVH criteria on the ECG. They can have tall QRS complexes and still have amyloidosis. All of you have seen echoes that look like this. If you have thick ventricles, biatrial enlargement, and then if you have some other evidence of infiltration, such as a pericardial effusion or a thick interventricular septum, then that's very, very suggestive of amyloidosis. But in most cases, the echo just shows LVH, apparent LVH. And there are 4 examples there of different patients with LVH. And the problem is that it's very difficult to discriminate between the various causes of LVH from echo alone. And so those are patients with hypertrophic cardiomyopathy, amyloid, hypertension, end-stage renal disease, and the last one is Fabrys disease. So in that context, some years ago, the Cleveland Clinic group proposed a particular pattern of global longitudinal strain abnormality and apical sparing pattern that in that inaugural paper had quite a high sensitivity and specificity for the diagnosis of amyloidosis. I'm sure you've all seen beautiful MRI pictures for amyloid, and the typical finding is this profound enhancement of the myocardium because of the expansion of the extracellular volume and the inability to null the myocardium. The tracer dissipates rapidly from the blood pool. The myocardium is always brighter than the blood flow, even if you image them several minutes after the injection of the gadolinium, and that's a very characteristic finding of cardiac amyloidosis. We can also do absolute T1 measurements or the extracellular volume measurements, and this is rapidly becoming a very powerful prognostic tool in all of cardiomyopathy, but also in amyloid. And this is data from our group showing that in amyloidosis, an expanded ECV is a sign of very, very poor prognosis. But remember that echo and CMR need a biopsy for confirmation, and that is the advantage of a PYP scan. Today, if you have a very strongly positive PYP scan and a negative serum study for AL, you do not need a biopsy to confirm this. So here is a patient that I saw recently, a 51-year-old, again, very healthy guy who was admitted with new onset atrial fibrillation and severe congestive heart failure. And it turned out that his father had died of a polyneuropathy 10 years ago because of a VAL30 MET mutation. This is one of the more common mutations that predispose to hereditary amyloidosis. Now, the patient's ECG showed a left bundle branch block. He was admitted at night, and at 8 o'clock in the morning, he had an echo that was suggestive of amyloidosis. And when I asked him about his father, he said, "I don't know whether my father had cardiac amyloidosis because he declined a biopsy." Right? So this is just a decade ago. He had a very sophisticated diagnosis of VAL30 MET mutation, but didn't want a biopsy, so we didn't know whether he had cardiac amyloidosis, and the biopsy was the only way to make a confirmed diagnosis of cardiac amyloidosis. So my guy, after the echo at 9 o'clock, goes down to my lab, has a PYP scan, an hour later, we have a confirmed diagnosis of amyloidosis with a diagnostic confidence of 100%. And this is how this test has actually transformed the field of cardiac amyloidosis. We can do this without a biopsy, and because of that, we've begun to recognize that the prevalence of amyloidosis is much, much higher than we ever thought. 13 to 15% of elderly heart failure patients with preserved ejection fraction and LVH have amyloidosis. Now just think about the implications of that number. There are about 600,000 new heart failure patients diagnosed in the US every year, and 50% of them have preserved LV systolic function. So even 10% of that is a huge number. We're finding, and studies are showing, that is a significant proportion of patients with severe aortic stenosis and paradoxical low gradient aortic stenosis have amyloidosis, and that is raising a lot of questions about the appropriateness of TAVI in these patients. And these are some of the studies that established these data. Now, just 10 years ago, Rodney Falk, who's a amyloidosis expert, who some of you might know, wrote in a review article, it's for unclear reasons, senile cardiac amyloidosis is almost exclusively a disorder of males. And I think this is what we all grew up learning. And from the PYP data, we know that this is not true. In fact, in our own series, about 10% of patients are women. This has been reproduced in multiple studies. In fact, autopsy series show that even a much larger percentage may be women. And again, the ability to make this diagnosis non-invasively has transformed our understanding of disease. We can now screen family members very easily. So if you see a proband, all you need is a PYP scan to test whether there's cardiac involvement. And most excitingly, it has hastened recruitment into clinical trials. Now, this is an area where currently therapeutic nihilism prevails, right? We don't have any specific therapy for amyloidosis. And here is a slew of therapies. In fact, one of this RNA inhibitor molecule, which is produced by Alnylam, just reported 2 weeks ago for a neuropathy study. And the results are just mind-boggling. It met every endpoint, primary, secondary, tertiary endpoint. The p-values were 0.0001. And so there's a lot of excitement in the amyloid field. There are many other drugs that are being tested in phase 3 trials as we speak. And many of these clinical trials have now taken away the requirement of a cardiac biopsy for recruitment of patients into clinical trials, and so they're able to recruit much quicker. So the lay of the land in terms of cardiac imaging for senile and AlAmyloidosis, there are a couple of PET agents that are being tested now. These are all agents that were developed with cerebral imaging for A-beta amyloidosis in association with Alzheimer's. But we now know that both of these agents are taken up by both AL and ATTR amyloidosis in the heart. The bone tracers, pyrophosphate and sodium fluoride, for some reason, are taken up only by TTR amyloidosis. It's tempting to speculate that this might be something to do with calcium metabolism, but we've never been able to prove it. But it serves as a good clinical method to differentiate AL from ATTR amyloidosis. Of course, CMR and echo that are positive in both of these. Now, these are some preliminary data. I want to hasten to add that this has not been peer-reviewed except in the context of abstract presentations. And Ahmed Mashri, who worked on this, was one of the young investigator finalists at our recent ASNC National Conference. But this is what our data are playing out. We have about 103 patients who've had multimodality image testing. And of course, as expected, with PYP as the standard, CMR has a very high sensitivity. If the CMR is negative, it's very unlikely to be amyloidosis. But all that lights up on gadolinium, turns out that all of that's not amyloidosis. The specificity is not as high as we thought it was, which is understandable. And we are not able to reproduce the high diagnostic values of longitudinal apical sparing strain pattern. I don't know why that is, but consistently the original data are not panning out. Now, it's really interesting to speculate as to why the apex is not involved. Now, here is a patient who has the typical longitude. This is a polar map showing segmental strain, and anything that's not red is abnormal, right? So you can see that all over the mid-ventricle and the base, the strain pattern is abnormal. But in the apex, the strain pattern is normal. So this is the traditional apical sparing strain pattern. But on the MRI, you see that that's exactly where the gadolinium is. It's in the apex there and some in the base. And in fact, if you look at the PYP scan, you see that the apex lights up the brightest, right? So it doesn't seem that it is the actual deposition pattern of amyloidosis that results in this apical strain pattern. So there's a dissociation between anatomy and function here. And so I don't have an answer, but we're very interested in looking at this as we go along. And finally, I want to talk a little bit about RV assessment in heart failure. And this is something that we've been doing fairly recently and are quite excited about the results that we're finding. Now, ventricular function assessment is a traditional bailiwick of nuclear cardiology, and John has done a lot of work in this. But there are two approaches. As you can see, on the left side is a traditional SPECT or PET, where the injected tracer tags the myocardium. So you see the myocardium, you derive then cavity volumes based on endocardial definition, and you calculate the ejection fraction. The other traditional approach is that of radionuclide ventriculography, where you don't tag the myocardium, but you tag the blood pool. And you don't derive absolute volumes, but you derive ejection fractions from the difference in counts between systole and diastole. And an advantage of radionuclide ventriculography is that you don't have any geometrical assumptions. You don't assume that the LV is an ellipse or a hemisphere and use those assumptions to calculate volumes and ejection fraction. And that may be particularly useful for RV function assessment because the RV is not a geometrical structure, right? And that is one of the big problems even with MR. If you go to the MR lab, you have to create a stack of images and painfully draw the borders in each of those stacks and convert that to an EF calculation. Now, the RV is not well seen on gated SPECT. The RV is a thin wall structure. As you can see, you can barely see the RV. And there is the RA always overlaps. There's overlap between the RA and the RV. And so it's really difficult to get good RV ejection fraction numbers from traditional planar ventriculography. And so Here is a three-dimensional mugger, if you will, a three-dimensional left ventricular ventriculogram. So this is blood pool tagging, but instead of doing planar images, we do a three-dimensional image, and see how beautifully you can see the RV. This is early days. It requires a little more calibration. But what we're seeing, so here is an example of a patient. The LV is dilated, severely dysfunctional. You see but that the RV function is normal, right? All the walls of the RV are contracting well. Here's an example of a patient. Look at the echocardiogram, and based on the tricuspid annular plane motion, this echo was reported as showing normal RV function. That's how I would report it. The TAP-C was 2.1. The RV systolic function is normal. If you look at the ventriculogram, you see that the base is moving. That explains the normal TAP-C, but the rest of the right ventricle is not moving. And it is this ability to look at regional function of the right ventricle that I think is a unique advantage of the gated blood pool approach. And so this RV ejection fraction was calculated 35, which is modestly reduced. And in fact, in some of the early studies, we were able to go into the operating room and look at the anterior wall in patients who are undergoing LVAD implantations and really correlate what we're seeing on the gated blood pool SPECT. So here are some examples of RV regional dysfunction. The first one is a patient with completely normal RV function. The second is a patient with global RV dysfunction. The third is third one. Hope it plays. So these, they don't play. But these were examples where you could identify RV regional dysfunction in addition to RV global dysfunction. And in fact, in some very preliminary data, when we looked at this in terms of patients who were going for LVAD implantations, now as a routine investigative procedure, we do gated blood pool SPECTs in all of these patients. And consistently, you find that the RV free wall hypokinesis is predictive of post-LVAD RV dysfunction. And I think there is a reason for this, and that is when you put in an LVAD and you decompress the left ventricle, the septum becomes a little dysfunctional, right? And we do use echocardiography to optimize LVAD flows, but nevertheless, here is an example of a patient whose LV, you can see the LV before the LVAD implant here. And here is the LV after decompression. You turn the LVAD on, and you can see how the septum becomes dysfunctional. And so in the LVAD patient, two things happen. One is RV function becomes very dependent on free wall function. And secondly, you have an increased volume overload from before the LVAD implantation. And both of these things work adversely to affect RV function. Here is an example of a patient who had some RV dysfunction before the LVAD implantation. This is a study that was done 1 year post-LVAD. And look what has happened now. The LV is decompressed. It has reduced in size, but the RV didn't like the LVAD at all. And it has become dysfunctional and very dilated. And so we are looking at this with a great deal of interest. There are many other applications. I could talk to you about this for a whole day. And for the sake of time, some of the other things, exciting developments in the field of transplant vasculopathy, the demonstration of normal myocardial flow reserve with PET has a very, very profound positive prognostic message. So patients with post-transplant patients, if you do myocardial flow reserve and it's normal, their chances of having an adverse coronary event in the next several years is very low. And again, it's clinically a very challenging area. We don't yet have any sort of imaging technique, including coronary angiography, because this is a disease of small vessels. It's a disease of the vessel walls. It's very difficult to diagnose. And so this may show some promise. LV dysynchrony assessment, which has been a focus of my lab, is again another potentially very useful application of nuclear cardiology. The other very challenging areas: device infections, LVAD infections, driveline infections, ICD, CRT, generator and line infections, and FDG imaging with PET is rapidly growing in importance. We're finding that it can provide some very useful clinical data in these circumstances. And finally, MIBG imaging, which, as you know, is a sympathetic nerve terminal function imaging agent and was approved by the FDA, I think it was last year, for prognostication in heart failure. This was the ADMIRE heart failure study that actually established the value of MIBG imaging. As you can see here, in patients who have normal cardiac function, there is very avid uptake of MIBG in the myocardium, and so the heart to mediastinal ratio is good, is greater than 2. In patients who have advanced heart failure, the myocardium ceases to take up MIBG, so the heart to mediastinal ratio is low. And in 1,000 patients, it was shown that the heart to mediastinal ratio very nicely differentiates people who have adverse events on follow-up and people who don't. Both mortality, but more importantly, what is shown here is that for the first time, we have a tracer that might be specific for arrhythmic events. And I know that you're all participating in the next chapter of the MIBG trial, so that's very exciting. And so I will stop where I started, and what I tried to show you was a smattering of applications of imaging, and particularly radionuclide imaging in the heart failure patient. Thank you very much.
Prem, thank you very much. An excellent overview of where radionuclide angiography fits in the assessment of people with heart failure. I'm kind of curious about the whole right ventricular radionuclide angiography in terms of using SPECT, and we've talked about this also. What is the variability associated with those measurements? I mean, can you be really confident when you see someone with hypokinesis, for instance, on an RVG SPECT, that it's really present, or it's just due to loading conditions that may change?
So it may be due to loading conditions. I mean, that's a little difficult to assess. But we have 2 cameras, and we usually acquire the SPECT on both cameras. And I see good repeatability, at least for this qualitative assessment of global and regional function. Now, the numbers sometimes are beyond physiological ranges, and it needs to be calibrated. But we're using it primarily to look at global function, and then is there regional dysfunction. Our heart failure guys seem to like it. You know, they're difficult to perform, and we're doing a lot of them.
Great. Are there any other questions in the audience?
Thank you. Excellent overview. So I'm one of the heart failure guys. I really appreciated all the aspects of that talk. In the same vein, on the RV imaging, have you seen those serially over time, and how they change with time?
Yeah. You know, as I said, the data are not peer reviewed, so I hesitate to sort of present it. We have, and that one example I showed you was a graphic example of how the RV dilated over time. You know, it's a as you know very well, it's a difficult area because the diagnosis of RV failure after LVAD is not that easy, right? So our criteria were the requirement for inotropes for 14 days, for more than 14 days post-implantation, and the requirement for an RVAD. And this, as you know, and for those of you who are not heart failure docs, this is a really important question. When you take a patient for mechanical support, do you give them just an LVAD support, or do you give them a BiVAD support? And this is where we're coming from. And I don't have a specific answer to your question. You can see changes. You can see gross changes over time. And I think we have about 115 patients now, and about 20 of them pre and post. But the technical challenges of performing this test in somebody with a VAD are not small. And in some patients, you simply cannot get images because of the hardware sitting in front of the heart. So it's not as easy as it looks on the slides. Hi.
Excellent talk. Just a quick question on your initial slide where you showed, the use of nuclear SPECT to rule out ischemia in the presence of heart failure. How do you reconcile that with the heart failure guidelines, which still say, coronary angiography should be the thing to go to when you have heart failure?
So that's a great question, and that was the basis of the imaging in heart failure study that I showed you. So today, and I think if patients have angina, if patients have heart failure and angina, then I think everybody's agreed that they should have an angiogram if they have angina. But as we know from studies like the Christmas study, only 40% of patients with ischemic cardiomyopathy actually have angina. So again, they can run up a flight of stairs, get ischemia, and have stunned myocardium without angina. So our guidelines now give a class 1 indication for coronary angiography in that circumstance, new onset heart failure. And there's a lot of disparity between the heart failure guidelines and the SKY guidelines and the ASNIC guidelines and the ACC guidelines. I think that if you have patients who have a lowish probability for coronary artery disease, say a young woman with new onset heart failure, I don't think those patients, I think you can triage those patients with a radionuclide angiogram from a stress study. The older patients, sometimes you do encounter left main disease. That is the cause of new onset heart failure. So I think you have to take it on a case-by-case basis, and that's probably the reason why we've not been able to achieve consensus in the guidelines. And I participated in the appropriate use criteria for heart disease, and again, it's very difficult to come to a consensus. But I guess, there are two issues. One is the concept, right? That just because somebody has triple vessel epicardial disease, that doesn't necessarily mean the LV dysfunction is actually due to that disease, particularly in moderate disease, as I showed. That's really important, I think, to keep in mind, because then the objective of revascularization in that patient becomes questionable, particularly if they don't have angina. The second is the practical implication of what you do, and I think we're on less firm ground there.
On that same note, because we talk about the issue of, whether we should cast someone or not cast someone, and then we get to the issue of once you have disease, what do you really do?
Right.
And, in our own lab, if someone has unexplained heart failure, a lot of times what we'll do is a first test, actually, in a relatively young patient, is a CT angiogram. Because if you can exclude disease, you're pretty much done there. But once someone has disease, and I like your approach because I think, the whole issue of rest redistribution thallium. The concept is great that people who have extremely tight lesions, 90% or 100% occlusions, et cetera, where you want to see if there's still viability in those areas. But what we do is we either do rest redistribution thallium followed by a stressed myocardial perfusion scan to really see who's ischemic. Yeah. Or we do a nitrate-enhanced rest study followed by a stress pharmacologic test, because most of those people can't exercise. And I think the addition of the ischemia addition, I think, is a much more valid way, as you stress, Prem, in terms of looking at who would improve post-revascularization than just the rest study alone.
A full viability study should include ischemia assessment.
Any other questions? Okay, well,
thank you very much.
Thanks very much, Prem, for a great lecture, and we'll see you all next week.